Well, welcome back everybody to the final part of our session. So we have a panel discussion with lots of really interesting speakers who are going to be speaking about the importance of research in the NHS. And we're going to start with Nathan. Are you there, Nathan? Hi, Nathan. Great to have you here. So I'll briefly introduce you. So I've known Nathan for quite a while. He's an expert by experience. He was the participation lead in CAMHS in Oldham CAMHS and Pennine Care, where I work, and then he received a Northwest Royal College Psychiatry Award for participation lead a couple of years ago. He's also a young consultant to the Royal College Psychiatrist Child and Adolescent faculty, where he's been very engaged in a lot of the work we do, particularly around climate action. And Nathan, I know that you're very interested in research. You're also a consultant to my depression study, which hopefully will get going quite soon. And you've also been involved with the Department of Environment, I think, as well, with research. So thank you for coming along. I'll disappear now. My face will appear after 6 minutes. You know, you'll be almost at the end of time. Looking forward to what you have to say.
Thank you, Bernadette. Good afternoon, everyone, and thank you for allowing me here to have a few words. So I suppose I'll firstly reflect on my own time as a service user and the few of the interactions that I had with research during that time before moving on to how my career has gone so far. And so initially I became a service user when I was age 16 in CAMHS, and initially it was just a standard service where I was just receiving care, therapy and medications. But it was only during that time when I became more engaged with the service that I was able to get a greater feel for the research that was being done by some of the clinicians that were actually there. And it was that point where I was receiving that academic knowledge almost, and that sort of having that instilled into me from that early point is definitely some of what I would consider to be a part of the springboard which sprung me to where I am today. And so moving on from that time to my time working as a staff member, engaging with patients, service users and their families from a research perspective became quite a more prominent part of my day-to-day life. And when it came down to seeing that and how it was implemented on an individual level for other people and other patients, seeing those benefits, seeing the times when a young person was actually able to receive or go through at least this new form of research, and at the end of the day, seeing their own progression and their own realization of what they're undertaking and how it's going to benefit others, and seeing the direction it's going to be sending them in, it was incredibly satisfying for me because it showed elements of my own journey, and that was something that became quite important to me. Now, moving forward to DEFRA, to some of the other further afield opportunities that I've had, it's been a case of now doing that on a regional and national level and seeing how it's implemented from a policy perspective. And as a young person who managed to see that from quite an early age, again, it further instills this lifelong learning approach, which has always become more and more important to me, especially when reflected on my time as a service user. And basing upon that, my own journey and seeing how it's been able to progress, I've noticed that my own approach to just general academic life, separate to clinical implementation, it's been quite interesting because my own background was very not academic in the slightest, and now here I am, a medical student, and again being further involved with more studies and just seeing the way that things have changed for me as an individual, and then seeing the impact of those studies, this research, the implementation of it, and the potential scope for it going further upon others aside from myself. It's become quite personally satisfying because it's that arc almost where you go from one place which is very, very different to where you were and where you ever thought you might be, to something very, very different. And now, reflecting on my current circumstances as a medical student, it's gone further, and it's looking as though it will go further still. And from an abstract perspective, I suppose it's a case of seeing the way that it's informed my character and changed my own character. And that's more the aspect that I can speak to at this stage. But again, when it comes down to my own engagement as a staff member, as a participation lead, and as a consultant to the Royal College, when it comes down to their own actions from a clinical perspective, it's become, I'm trying to think of how best to describe it. It's very personally interesting to me because of the way that it has changed me going forward as a person. And so the implementation of those actions and those clinical decisions from a research perspective is something that has become very, very dear to me, and something that has ultimately led me to where I am today. And I suppose this leads to quite a quicker perspective, but I'd be interested to hear what everyone else thinks when it comes down to the actual individual perspective on research and how it's affected them when it comes down to their own journey as a clinician. And so if Binaki, if you'd like to come back, and if there has been any questions, I'd really like to hear from them.
Thanks very much, Nathan. I completely forgot to tell people that you just started medical school, which was, such an amazing achievement, Nathan. And I know you had a lot of hurdles to get through to do that, but it's just been so great to see how the research is so important to you in terms from your own personal clinical perspective, but also how you've seen how it is so important from a much more general perspective for the benefit of everybody's care within CAMHS, and that you're now on your own journey to hopefully becoming a clinical academic in child psychiatry, which will be absolutely fantastic. Look forward to having you as a colleague in the future. Just looking to see if there's any comments in chat, then please put your messages in there, or put your hand up if you'd like to ask Nathan any particular questions. I guess while we're waiting for that, so our medical director Alice Seaborn has said this is great recruitment. So very proud to have recruited you to our cause, Nathan. From your perspective, do you have any thoughts about how we as professionals, what more we need to do to get the message across, has been said earlier in the day today, that research isn't something out there, it should be part of on everybody's radar, and it is part of good clinical care. From your own personal perspective, do you have any sort of top tips for us as to how we can engage clinicians more to understand that? Because often the perception, as you probably know, is that this is something that service users aren't particularly interested in.
Yeah, and so I would almost treat research the same way that I would consider treating participation, wherein if you have it as something that is on the menu, at least on the side for a patient, service user, even their families, then it's something that they can either dip their toe into or dive headfirst into, and they can run with it as much as they like. For me, research is something that absolutely informed my academic future, as well as where participation, it also informed the direction in which my career would go. And so that if you treat them in a very similar way, wherein the opportunities are there, the opportunities are showcased as much as possible, and showcasing the benefits to the individual, what participating in the research or participation more generally is, then I feel that you are more likely to gain a wider interest in it. If you showcase the more general perspective to those people who may be participating, what the benefits might be to them, then I think the interest will appear more, instead of, say, showing them just a summary of what the study would be, actually talking about what it is and what it would entail and what the potential benefits to them would be, purely on a basis of participating within it.
So advertising it more, but also, I guess, maybe not making the assumption that service users aren't interested in research until proven otherwise, but maybe making the assumption that everybody may be interested in research, and starting from that angle as well.
Absolutely, absolutely.
Well, thank you very much, Nathan, for your perspectives. I don't know how much longer you can stay. If you can stay to the final Q&A, that would be great. But if we move on now to Dr. Kirsten Windfuhr. Are you here, Kirsten? Hi. It's lovely to see you again. So just to let people know, this event started with your involvement as a member of the Northwest ARC, and then halfway through you've changed your roles, and congratulations on your new post, because now you work for NHS Benchmarking, and so you're in fact going to talk to us about barriers and facilitators to research and what NHS Benchmarking has done to try and improve data collection to improve patient outcomes here in the UK. And also just like to mention that NHS benchmarking here in the UK is seen as an international example, a really good example of how data collection, can actually happen and how it can be put to good use. So over to you, Kirsten.
Thank you very much. Right, I shall attempt to share my screen. Sorry. Can you see that?
I can see a screen. Yeah, that's great. Thank you.
Excellent. Thank you. Thanks, Banaka. And I'm really pleased to be here. As you said, I've worked with many colleagues on the call today in terms of my research career at the University of Manchester, but also have worked outside of research and commissioning roles, both nationally and locally. So I think Benchmarking Network sits sort of in the middle of that Venn diagram. So I'm definitely one of those more passionate people in terms of trying to help embed research in terms of building the evidence base and having it as core business of any functioning, well-functioning system. So just to cover off what is NHS benchmarking. So it has been running for a number of years, but I suppose some people who are very engaged will know all about it, and some who are less engaged won't know very much about it at all. So just very briefly, it is the in-house benchmarking service of the NHS. So there is an in-house benchmarking service in the NHS that covers all sorts of clinical areas, mental health being one of them. In terms of members, so there's over 250 members, 10,000 users of the data that gets collected in the benchmarking services that are available, and a large number of unique metrics that are collected. And in terms of the mental health coverage, 100% of trusts in England participate and are active members. That's the same across Wales, and there's very good engagement in Scotland and Northern Ireland. So there's incredibly good buy-in and really close engagement with providers in terms of the data, and it being driven by users of that data in terms of the key metrics. But it's not only providers, so it's also, I'm not even sure if I can call them this now, but clinical commissioning groups, as was, local authorities, and of course ICSs and ICBs, as they come on board as well, are becoming members to access the data and the services around the benchmarking network. So it covers a number of sectors, mental health being one of them. I'm going to focus in on children and young people today. So there's those 4 core streams that the benchmarking network deliver annually and monthly. In terms of that monthly COVID dashboard that came on stream when COVID came along. But there are also a number of other projects that happen around those core areas of work that fall from those core areas of work, really around everything from very deep dives to individual trusts or regions about particular issues and challenges, to more system level views around, for example, in London, having a census day and looking at a day in the life of the mental health system and the partners that it works with across the system. So both very deep specific dives and also system-wide views that the benchmarking network also engage in with providers and commissioners. I guess one of the core questions is around, what does NHS benchmarking actually benchmark? So I think it's safe to say that there's a wide breadth and a depth of data that are collected, and these data are provided from mental health trusts. So there's definite engagement and utility in that data, because it's not a small task to ask a trust to provide quite a lot of data. And we try and supplement that with publicly available data in terms of context, but across service models, activity, workforce, finance, all of those. So it's a definitive reference point for understanding the system. And over a number of years now, there's some longitudinal analysis as well. And in particular, it's curated by a clinical reference group and that provider feedback. So it's very much driven by the needs of members. And there are a number of products and outputs in terms of bespoke reports, organizational dashboards, and an interactive toolkit that every everybody can use to really do a deep dive into their own trust position against the national picture, against other peer group matches, for example. And there's about 3,000 metrics just in the CYP mental health benchmarking service alone. So there's a real facility to do a bespoke picture of what your service looks like in comparison to the national picture or other peer group matches, to really understand what the issues are and the challenges are, and also where things are going really well. Because of my research background, I tend to look at the data not only in terms of the benchmarking and in terms of it as an assurance function or a quality improvement function, but also what are the other questions that then poses, and how can we use that data to think about research priorities, particularly in GM. And just pick 3 examples around health inequalities, the impact of COVID, and things like organising care and service delivery issues. So very quickly, I'm actually going to skip over that one in the interest of time. The first one around ethnicity. So we can see that this is a comparison about looking at ethnicity of the general population of young people and the ethnic breakdown, and then looking at community services, and then looking at inpatient admissions. If we just look here at that green bar, which represents young people from an Asian and Asian British background, we can see 10% of young people are from an Asian British background in the general population. When we look at community caseloads, that is down to 4%. So there's an underrepresentation of young people from an Asian and Asian British background in community services and inpatient services as well. And that contrast, then when we look around young people from a Black and Black British background, so in the general population, that's around 5%, and that increases in terms of inpatient admission. So there's an overrepresentation in other young people from other ethnic minority backgrounds. So it's looking at that, it's looking at your service in the context of what that means in terms of, for example, understanding barriers to access, improving equity of access and treatment, and understanding your service in that way. So more so than understanding just what it's telling you, it's about what do we do with that information and how can trust use that to build a better evidence base around improving access, reducing barriers, and improving equity of access. Another example is around, I keep moving this, sorry. Another example is around the impact of COVID on, in particular, digital technologies and the uptake of digital technologies. That's been one of the big impacts of COVID over the past 1.5 to 2 years. And here we can see on the left-hand side is the uptake of digital technologies amongst adult community mental health teams. And here on the right-hand side, it's the uptake sort of on a monthly basis, and uptake of digital technologies in terms of young people's services. And you can see young people's services have been quite agile in adopting digital technologies, in addition to telephone contacts and continuing face-to-face where possible. But immediately, this tells you more than just the picture as it is. What it tends to ask is what's been the impact of those mixed delivery models on patient experiences, on outcomes, on impact of staff. So these data tend to generate more questions. And I think if we start to think about these data in that way, so it's not just about the position as it is, but what are the questions does it then ask of services, of commissioners, about what the impacts of these changes are and what that means for service users and staff. Another example is here, if we just look at waiting lists, so waiting time to first routine appointment. So the benchmarking data can tell us sort of what the position is. So 528 young people per 100,000 population are waiting for a first appointment. How that's changed compared to last year, it's down 18% compared to last year. And it just happens to be in the green bars, our trust providers in Yorkshire, for example. So the blue in the background is the national picture. That's every single provider, and these green bars just tell you where those particular service providers sit in relation to the national picture. But in addition to telling you that benchmark information, I think what we should be thinking in terms of the data, what does that mean, and what's the actual question behind that? And there just seems to be great variation, for example, in terms of how capacity and demand are managed. And more than telling us the benchmark position, it's about asking that next question about, well, what does that mean in terms of variability in managing capacity and demand? what does a good system look like? How do services do it better? How do some services do it better than others? And what can we learn? And how can we build the evidence base about managing capacity and demand better? So I think the benchmarking data, it gives you that platform to start to ask those deeper questions around what does it mean in terms of our priorities for research and GM, and more widely about how we can improve services and build the evidence base around that so that we can do that QI piece afterwards based on the evidence. And as you said, Bernardka, it's not just about looking within the UK and asking those next questions around what the benchmarking data are saying. It's about comparing internationally, so looking across different countries. Nobody does this perfectly, but one of the main issues is around for services is around young people's length of stay in hospital, for example. So in England and Scotland and Wales, you can see here, there's quite long lengths of stay. But here at the other end, we see some countries have incredibly short lengths of stay in terms of young people in inpatient services. So it's about looking beyond the UK and understanding what happens in different systems, what are the different care philosophies that influence those service delivery models, and what could we learn about how to do things better, and how do we build the evidence base to improve some of those more challenging areas for services. So it's not just about looking in the UK, it's about looking externally and working collaboratively with others in other countries who do it differently and perhaps better, and then sharing our successes and helping them with their challenges. So there's definitely this international collaboration that's been very useful, and something that we're now taking forward actually in the Northwest with some of our Northwest providers as well. So this is an ongoing piece of work, looking at different care philosophies and service models and the impact of those, and thinking about designing, design of services, for example. Nearing the end here, so I think as important as it is for providers when they receive all that information that they get, and it's a huge amount of information to digest, and looking at those data in terms of more with a research lens, not just a quality improvement or a quality assurance lens. It's about thinking about that next question about what does it mean and how can we build the evidence. It's equally a question for commissioners, and Sophie, I saw your question come up around commissioners and how do we convince commissioners. And I think things like the ICS tracker that NHS Benchmarking have developed, which brings together in this first phase just all the publicly available information across population health, workforce, activity, capacity, and brings that all together into one tracker to sort of get that system overview. It is one way to try and bring in commissioners to use that information to understand what the system looks like and to work with providers to understand what the system looks like. And that second phase now that we're working through is to establish pilot sites, and it'd be interesting if GM were a pilot site around this, about how to integrate that publicly available data in this ICS tracker with the NHS benchmarking data from providers, and to try and integrate that data, thinking through permissions and processes and all the rest of it, but to give us that really rich source of information around where mental health sits within the wider system, and to have that joint conversation across providers and commissioners and have that joint system view. So very quickly, I guess, one of the key questions was, how does NHS benchmarking do it? It's a lot to ask of providers in many senses. Everybody's very busy. And there are other priorities for sure, but it's the importance of that data and the utility of that data, and that's quite clear in terms of the clinical leadership engagement and that building of those trusted relationships and supporting providers to use that data in any way possible. It's the data, it's the quality of the data, and it's a diagnostic resource at this stage that providers do rely on. And it's that additional interpretation, both nationally and locally, that NHS benchmarking provide that perhaps other organisations or services don't, that exist more widely within the NHS. But I would challenge around how do we use that data better? It's a huge resource. How do we use that better to develop the evidence base and inform continuous quality improvement? So those are just some examples of questions that occur as I'm looking through that data, thinking about the research priorities in GM. How could we use that data in a more effective way? But I guess my question back would be, how do providers, how do commissioners use the data available? So there's 4 or 5 commissioners, in GM that are members. All mental health trusts across England are members. how do commissioners and providers use their data to drive research priorities and build the evidence base? And I guess I'll leave it there.
Thank you very much, Kirsten. As you say, it raises more questions than answers, but it's a brilliant example of data collection. And one thing I'd like to come back to at the very end, hopefully if we've got time, is how you manage to get this buy-in, because you get incredible buy-in from trusts. And we now have challenges to collect data, and that's something you've done really, really well. I'm going to move on now to Dr. Guy Northover. It actually segues in really, really well to Guy's work. And there was a slide there around inpatient stays. And this is the area of work that Guy has been involved with as the national lead for getting it right first time. He has focused on inpatient care. And I'm really looking forward to hearing, Guy, about your experiences in terms of what data you found was available and how you think we can better collect and better use data to improve young people's experiences in admissions. Thank you.
So I've just lost my screen. Am I sharing my screen?
I can see it, yeah, I can see it. Yeah.
Fantastic, brilliant. Well, I've lost everybody else, but if you can see my screen, that's fine. It means you can pull faces at me and I really wouldn't have a clue what's happening. It's brilliant actually, isn't it? Because my presentation is going to lead on really quite nicely from the benchmarking presentation. And it's also this fantastic position we're at where we realise the importance of data and what we can do with data. I think there's a little bit of my presentation about where benchmarking data ends, where clinical interpretation starts, and actually where research is also needed. And I've got 7.5 minutes to try to get through it all, and I do enjoy talking, so it's going to be a real challenge, but let's see how I go. So first of all, when we're thinking about the Getting It Right First Time project, of which I'm the clinical lead, it's a national programme which has got a focus on quality improvement. And basically what it's doing is it's looking at variation, and then it's determining what variation is warranted and what variation is unwarranted. And one of the challenges with research, and that's shown by this paper by Harrison, is a vast amount of studies look at variation and make the assumption all variation is unwarranted, and that's absolutely not the case. The GIRFT data has come from multiple databases. The MHSDS has been one of the main ones, but also the NHS benchmarking data. We also use fingertips and other CCG databases as well. The biggest challenge with the data that we've got is this 2018-19 data, and the next stage with the deep dive visits was interrupted because of COVID. So we did our first deep dive visit pre-COVID, and the last deep dive visit I did was on Wednesday, which is actually Greater Manchester Provider Collaborative. So what we do once we've got the data is we develop a data pack where we can start looking and identifying where there's variation. We would then have a deep dive visit to have a clinical discussion around the data and to understand from a clinical perspective why that variation is there. From that, we can then develop ideas of best practice. The data is around general admission and eating disorders with some children units in there as well. And the final part is we're developing a national report and national recommendations. Right, so that's it. And it's just a reminder here that it's quality improvement. So quality improvement moves the bar, it improves the quality of care, but it doesn't actually it doesn't actually move the very better part. And that's one of the things we need to think about when we're looking at research. When I started off the quality improvement program, sorry, the GIRF program, we had a very short questionnaire which was looking at the state of quality improvement at a service level. And it was quite worrying actually to see, based on this very short questionnaire, so this is absolutely nothing I'd ever want to publish because it would be shot down in pieces, but it did indicate that there was less understanding of what quality improvement is at the service manager level than perhaps we expected. We also found out, as no surprise, through our deep dive visits, that those organisations that have got a clearly defined quality improvement approach were able to demonstrate much more positive variation within their data. We do need to notice that within quality improvement, we have to be monitoring outcomes as well. And one of the great weaknesses through the GIRF data was identifying how little outcome data is actually flowed up to the MHSDS to allow us to interpret. A vast amounts of process data is flowed up, but the actual clinical outcome measures, and in particular the paired outcome measures, was very poor. And if you don't know what a good clinical outcome is, then it's very difficult to drive quality improvement. Having said that, we did come up with some very interesting findings, which we've been able to interpret and look into and demonstrate some best practice around. So the first thing we noticed was the impact of staffing on the levels of length of stay within inpatient units. There's a very strong association with the number of staff on the unit and the subsequent decrease in the length of stay. The data that we looked at and interpreted, it didn't suggest that there was a difference between the type of staffing, it was just the number of staffing. But I do know from the NHS benchmarking data that there's also a strong correlation between the number of more senior staff on a unit and the length of stay. The next interesting bit is around restraint. So what we've done here on this chart is we've compared the levels of restraint per 1,000 occupied bed days within the inpatient unit and the associated adult inpatient unit within that trust. And what this shows is restraint is 5.7 times more likely in an adolescent unit than an adult unit in the same organisation. And not only that, when I look at this chart, I actually think this has got an exponential factor to it as well. So my guess here is that the worst an organisation is at restraint in an adult ward, it's exponentially worse for restraint on the child and adolescent unit. So whilst this data doesn't say why this is happening, it's absolutely crucial that we take this seriously and look at what's up, try to get that understanding of why we have such high levels of restraint. The next bit I was quickly going to look at is diagnosis. When I started the GIRF project, my headline message was, actually, we don't know who's coming into services, we don't know what we're doing when they're in services, and we don't actually know whether they're getting better or not. I think that's a bit negative. I think actually we do understand all of that, but perhaps it doesn't flow up to the national data sources quite as well. But as we can see here, if we're looking nationally in 2018-19, only 9% of young people had a diagnosis recorded in the national databases. And then the final bit of findings that I'd like to show here is the use of the use of paediatric inpatient units. So again, when I first identified this data, the amount of young people who were using paediatric wards was not quite as well known as it is at the moment. But we can see that when we look at this chart here, it shows us around about 70 to 80% of all young people who were subsequently admitted to an adolescent inpatient unit were in A&E at some point in the last 6 months. And actually it's even more scary than that, because this data excludes young people who end up in the independent sector. And these arrows also indicate the difference between a single provider collaborative, which doesn't use the independent sector. So there's massive variation, and understanding whether this is positive or negative is absolutely crucial. Because I knew I'd be able to talk for a little bit longer than just those things, I'm also just going to quickly mention the headline national recommendation that's come out of the report. So the headline recommendation is that there must be a clear strategy and plan on reducing the proportion of young people remaining on the inpatient unit for more than 60 days. But it's more than that, because this is a plan that's got to include a review of who it is who's being admitted into the inpatient unit. So are we admitting the right young people into the units? It's got to review what's happening when the young person is within the unit. Are they receiving the right level of care? And it's got to review the discharge processes as well. So it's not just about we've got to shorten the length of stay, it's we've got to get all those processes right so that young people are receiving the right level of care and in the right place. This is just indicating as well the significant variation in the length of stay across the estate. And this is all squashed down quite considerably by this one outlier here, where the average length of stay was over 300 days during the period of data collection. If we exclude that, we're still looking at a variation between around about 112 days down to around about 36 days. Why is this important? Well, we've done a financial analysis to break down and see what this means. And if we were to bring all units to the median point, which would be 55.6 days in 2018-19, that would free up 14,200 beds, which is bed days, the equivalent of 300 new beds nationally, which is probably the equivalent of 7 or 8 new inpatient units. And if anybody can find the staffing for 7 or 8 inpatient units lying around anywhere, then let's do that instead. But I honestly don't think we can find the staff to do that. So my final slide. GIRF, it's good, it gives us lots of good information, but it doesn't develop best practice. It doesn't lead to precision, it just leads to improvement. We need the research to really drive the improvement. We need research to take us to the next level so we can start doing things differently rather than just doing what we're already doing better. It doesn't validate or assess new treatments. It doesn't make that step changes in care. and it doesn't explain the root cause of the variations. So we really have to look beyond the data, beyond the quality improvement, so we can drive that step change to where we want to get to in the future. I've run, oh gosh, I'm a minute over time. Sorry, Benatka.
You've done so well, Guy. Thank you so much. There's so many really important findings there. But what GIRF does demonstrate the importance of being able to collect data in order to inform our understanding of what's going on, then develop those research questions to affect change. Without, you know, so knowledge is power, isn't it? Without the data, without the knowledge, we do not have the power or the ability to even think about affecting change. Thank you so much for that, Guy. And at the end, the question I'd like to leave you with is, how do we improve better data collection services? But I'll park that thought with you for now, because I'm sure Pratibha may have something to say around that. So thank you very much for coming along, Pratibha. Pratibha is the National NHSE Deputy, I get your title wrong all the time, I have to read it out, Associate National Clinical Director for Children and Young People's Mental Health for NHS England, and a consultant in child psychiatry at Pennine Care. And you're going to finish the presentation this afternoon, Pratibha, by talking about the importance of research and data and outcome collection for NHS England, why that's important for the strategy and also the quality improvement. Thanks, Pratibha.
Thanks, Benatka. So I haven't got any slides. I don't know whether that's a good or a bad thing. I think, Benatka, the focus of my talk was a little bit more around clinical academics, if that's okay, because I think we've already heard fairly clearly from Guy and Kirsten and others about the importance of data and outcomes. So we've already heard, I think, fairly articulately from previous speakers about the importance of research and improving outcomes for young people, for patients and local communities. We know that research active organisations are safer, they improve the outcomes and the quality of care that they provide. But also, I think Michelle's highlighted the importance around staff recruitment and retention. And we know that using the evidence base, we can shape services, we can reduce unwarranted variation, as Guy and Kirsten's already highlighted. But also, ultimately, I think, understand the causes of mental health disorders and improve treatments as well. With the impact of the pandemic, I think now more than ever, we do need to think about how we innovate and provide services fundamentally differently to reduce those treatment gaps. And Kirsten's also highlighted some of the opportunities, I think, with the development of integrated care systems. So we know that there are strong socioeconomic determinants of poor mental health. So being able to really understand some of those causes, I think, really helpfully influence research, but the way that we commission and provide services as well. So NHS England and the NHS has a duty of responsibility to promote research and the use of research in everyday decision making. And we do that in lots of different ways. So one of those is really supporting the use of research in the commissioning of services. And I think it'd be really helpful to understand how decisions and opportunities that we might have at a local and regional level as well as national. So some of you will be really aware of some of the national programmes that we have around children's mental health. So the Children's IAP programme, the rollout of our eating disorder services, mental health support teams. That's all been based on research and evidence and being able to demonstrate to Treasury and government the impact of some of those interventions. And the other, I think, really unique opportunity is really creating an NHS environment that fosters research. So we've heard from a number of speakers around the role of the applied research collaboration, so our ARCs, the academic health science networks, the CRNs. But I also think that there are some important opportunities by partnering clinical services, frontline services, academic institutions, as well as industry. And this is where I do think the research infrastructure becomes so critically important. I know that we all know that I think participation, engagement with commissioners is really important, but I do want to just touch on the role of clinical academics. One of the challenges that we are increasingly seeing, I think, particularly within mental health services and children's mental health services, is not just the challenges about undertaking research, but actually the implementation of research into clinical practice. So I do think we significantly lag behind physical health services with this. And this is where I do think clinical academics working within clinical frontline services play such an important role. So they are front-facing, they work with young people, with families, with local communities, they deliver those interventions, they understand the evidence base and the gaps in the evidence base, and also the challenges in delivering some of our services. I do think we do need to think more creatively about how we provide services, because we know that with the pandemic, with workforce shortages, we do need to be more creative in some of those solutions. So I do think clinical academics not only provide an opportunity to innovate, to test some of those innovations, but also I think to support implementation. And we've heard, I think, from a number of speakers earlier today around some of the fantastic work that is going on within GM. So Kath Aldridge's input to the PAC study, Sophie's input to the Children's Research Unit. Paul French and I have also been involved in supporting the evaluation of the Resilience Hub within Greater Manchester. So some of you will possibly be aware of the Resilience Hub. All of you, I think, will be very aware of the Manchester Arena attack in 2017. And we developed a response within GM that's really kind of influenced what's happening nationally with the emergence of EPRR mental health guidance, but also in the development of staff wellbeing hubs as well. So we know the research that happens locally can have such a huge impact. But the question that I guess I want to leave everyone with is, how do we develop a sustainable infrastructure around research, and particularly thinking about the role of clinical academics within this? Some of you will be very aware with mental health research funding nationally, about a third of that funding currently sits within, I think, 3 or 4 organisations within England. Mostly, I think all of them within the south of England. And I do think there are some unique opportunities in the north of England, really, to strengthen some of those collaborations, to think fundamentally very differently about how we support research. So I was really keen, I think, to be part of this discussion, to hear about some of the challenges that people think does exist in the system. And I know I've had conversations with many of you around some of those challenges, but also very keen to hear about some of the solutions as well. So I'll finish there, Benadka. I know that it leaves us just probably 2 or 3 minutes for questions, unfortunately.
Thanks so much, Ratiba. Are you okay to stay for 5 minutes extra out of interest?
Yes, I am.
Yeah, and the other people on the panel? We've just run over by 5 minutes because you've all raised such important issues. So it would be really good to hear from people. If anybody wants to ask a question, we've only got a relatively small group, so you can either put a question in the chat or just put your hand up. So please do that. Ratiba, thank you for highlighting the importance of evidence base in terms of NHS strategy, in terms of providing evidence for commissioning services, because as you say, that is so important as well. And also for providing evidence to government, because that's something that we haven't really touched on before, and I think that's a really important thing to highlight. So while waiting for sort of hands to come up, I just wanted to ask, pick up those other couple of questions I asked earlier. So, and maybe I'll start with you, Kirsten. The remarkable thing about NHS benchmarking is that, and I know you know this, Ratiba, as well, and Guy, it's incredibly difficult to try and collect outcomes and data from clinicians on a daily basis from people, because everyone's so busy and exhausted. I think you mentioned the infrastructure, Ratiba, as well. Kirsten, can you comment on how, why you think NHS benchmarking has been so successful? Because there's so much buy-in, isn't there, in terms of organisations providing data? What were the levers that were there to do that?
So you're right. So out of all the sectors, mental health is probably the most engaged, I'd say. So 100% of all providers, certainly across England and Wales and Scotland and Northern Ireland. I think it comes down to that basic principle around relationships and engagement, and it being clinically led, I guess, first of all, and so curated in terms of the reference group and the steering group. So it's very clinically led. I think there's a deep engagement. So I've been here about 7 weeks. So I am brand new, 7 weeks. And I think there have been at least 2 or 3 presentations, engagement sessions, deep dive sessions with providers around the country. And so I think there's that constant engagement and feedback loop that's so important in terms of contextualizing the data and understanding it, and then developing other questions on the back of it. So I think there's that commitment to that engagement. So clinical leadership, feedback loop, and constant continual engagement with providers. And you're right, it's a huge ask, but I think it speaks to the utility of those data, and because it's clinically driven, because there's a feedback loop, and it's useful data, it's data that are, providers want these data and they want to see the national picture. And I think it's the utility of that data that drives that engagement, that continual engagement with the programme. And I think, of course, once you've got national engagement, it's achieving that threshold, and once you have national engagement, then it makes the picture all the more important, and it sort of drives that engagement as well. So it becomes a virtuous circle almost, doesn't it? So, but for me, having been here, it is that continual engagement with members at trust level, at region level, and also nationally with NHS England I partners and Health Education England partners. So I think it is that fundamental thing about communication, engagement, and relationships that drive it.
Thanks for raising that, Kirsten. I think you're so right, because I mean, if you just take it down to a research study level, you're much more likely to engage participants if they've got feedback about what's happening. And it's exactly the same for clinicians, isn't it? People don't see the point of providing data if they're not part of that feedback loop. So thank you for making that really important point. There's a question for you in the chat, Prateep. I'll come to you in a second, but perhaps Guy, do you just want to pick up from any lessons learnt through your deep dives and your GIRFT experience in terms of how to improve data collection?
I think, first of all, it really is, it has to be clinically led, and there has to be a clear benefit for the clinical teams. I've been sitting in deep dive visits with 50, 60, 70, 80 people listening to me talk about data for 3.5 hours. And as far as I can tell, not too many people are switching off, well, at least not switching off their internet connection. So I don't think that's because of my skills as a presenter. I think that's because it's the data. The data has been, it's been collected locally, it's been interpreted, and we're talking about the clinical interpretation. So what does this data mean to you? It's not about the assurance. It's not this data is telling you that you're doing something wrong. Does this data tell us something new that we can then use in a way that we can inform other services? Or does this data allow you to look at an area you want to improve? And do we have examples based on the challenges you have got from other areas and where they've managed to address that? So I think really, again, it just comes down to the usefulness of the data and getting us away from this point of data collection for assurance processes. CQC data collection, there's vast amounts of it, but we do know that actually CQC is very poor at identifying which inpatient unit is going to be the next inpatient unit that goes into, into special measures. So let's start trying to turn and shift the conversation. I'm presently saying that if we get data collection right, and if we get best examples right and get quality improvement right, we don't need commissioners. We don't need data to assure anybody, because we can see, you'd be a fool as a provider if you could see there's an area doing something more efficient and effective than you, and you weren't doing that. I don't know if that answered your question, Banaska, but
it kind of reinforces Kirsten's point again, is about the clinical engagement, asking questions that people are interested in, and having that continual dialogue really in discussion, isn't it, rather than data just pouring into a black hole. So thank you for reinforcing that as well, Guy, and I hope your data is put to good use. Can we perhaps sort of end the session then, Pratibha, with that question that's in the chat from Michelle, which is a really important question. What opportunities do you see with the new integrated care systems for trying to improve things?
So I think the opportunity is probably data linkage. So it's been work that's been happening, and I know there's been huge challenges within STPs and within local systems around data linkage. But it's absolutely critical that we have an infrastructure that actually has data systems that link and speak to each other. So I think work's developing in some areas to try and support that. And I do think we've often talked about some of the challenges with COVID. What's been really fascinating is that I think in a number of areas, they've used COVID to try and support better linkage, so better sharing of data across the system. So we've really got to be cited on some of the data that sits across education, local authorities, and other parts of the wider health and social care infrastructure. So I do think, Michelle, there are some real opportunities. It's just got to be a win-win for ICSs, because it's about place-based commissioning. It's about how we bring the whole health and social care together, really. And that will also, I think, contribute to more sort of pooled commissioning budgets as well.
Thanks, Britta. Michelle, if you're still there, do you want to come in on that before we finish? I don't want to put you on the spot. Hi.
I think the more conversations we can have about it, the better, and I completely agree. Data linkage is easy to say, but incredibly difficult to do. But the power of being able to join all that up across it, so the opportunities are great, but it's about understanding and comes back to relationships and being able to have a cohesive sense of what we're all doing, which also links to the data, because the data will help us have a cohesive sense of what we're all doing in this space.
Thanks, Michelle. We're meeting up with some PhD colleagues who've been doing some work around, I think, data linkage and bringing together different data systems. So I think depending on how that goes, we're very kind of keen to share that, I think,